anxiety disorder. So we're gonna have 4 presenter who will be presenting different type of disorder. So kalau saya bercakap ni tiba-tiba suara saya pecah ataupun tak clear, tolong stop. Okay, or you have any question, just stop me. So before we begin, kalau kita nak cakap anxiety dalam bahasa Melayu kan, what are the usual ataupun common words that we use in Malay, in bahasa to denote? Okay.
Gemuruh.
Risau, gelisah.
Right. Lagi? Apa dia? Risau, gelisah, gemuruh lagi, cemas, takut,
Gelabah.
apa dia? Lokman?
Gelabah dia.
Gelabah. Gelabah. Okey, lagi. Bahasa dialek negeri ada? Orang Kelantan panggil apa? Kalau cemas?
Cuak, Doktor.
Cuak boleh lagi?
Cuak.
Orang Kelantan cemas panggil apa? Panik?
Kalut.
Kalut?
Naling.
Apa? Kenaling kan? Kenaling. Naling ke kenaling? Kenaling, right? Okay, so kenaling. Kalau orang utara, Lokman?
Kalut.
Apa lagi bahasa utara?
Kalut.
Kalut, selain daripada kalut?
Kelam kabut.
Yang duk risau tak tentu pasal?
Risau.
Benda-benda kecil dia duk buat hingat.
Tak tahu lah.
Aku tak tahu dekat Kedah guna tak, tapi kalau di sini kami panggil ghaflah lah, ghaflah.
Oh.
Ghaflah maksudnya senang risau, benda-benda yang kecil pun dia risau juga kan. So
Dia ada setengah tempat yang guna Doktor, macam ada setengah tempat dia tak guna. Jarang sikit.
Ya. So ghaflah tu berasal daripada perkataan Arab ghaflah. Kalau dalam Quran kita tengok perkataan ghafilun, orang-orang yang lalai. Jadi anak-anak mami di Penang dia memelayukan penggunaan ghaflah tu menjadi ghaflah. Jadi orang yang senang risau dia panggil ghaflah. Siapa tu yang berbunyi tu? Okay. Right. So we have a lot of words in Malay to describe anxiety. So anxiety ni satu umbrella term untuk fear, untuk panic, untuk worry, right? Phobia dan etc. So it's actually, bila kita kata anxiety, it's actually an umbrella term for which covers all these spectrums of emotions. Okay? Kita tidak ada translation anxiety dalam bahasa Melayu. Dalam bahasa Melayu ni ada sesetengah perkataan tidak boleh diterjemahkan secara lengkap ataupun secara tuntas. Jadi kita perlukan kadang-kadang pinjam bahasa orang lain juga. Jadi saya tengok macam anxiety tu setengah-setengah orang digunakan dalam bahasa Melayu juga. Jadi ANZIETI, anxiety. So sebab tak boleh nak terjemah dalam bahasa kita. Anyhow, so dalam anxiety disorder, sebelum kita belajar pasal disorder, we have to understand that anxiety is part of our normal experience. Apa dalil dia? Anxiety is a normal experience. Dalil tu maksudnya evidence ataupun you punya cara you fikir apa nak mengatakan anxiety ni normal. Your argument for anxiety. Setengah orang kata anxiety is never a normal thing. I want to listen to your thoughts. Cara you fikir. Yeah.
Bolak-balik.
Apa dia?
Hati berbolak-balik.
Hati berbolak-balik. Right? Okay, so hati berbolak-balik. Right. Hati berbolak-balik ke mana tu, Hizo?
Ke mana?
Dari mana ke mana?
Tak pasti pula.
Right. So hati berbolak-balik. Okay, okay. Ada kaitan CP-CP lagi apa lagi? Kalau orang kata kat you, anxiety is never a normal thing. Do you agree or you disagree? If you agree, what is your argument for that?
Disagree.
Okay, so why do you say disagree?
Because normal anxiety is normal in certain situation. For example, during exam, but it becomes to excessive manner, then it is disorder.
Okay, so you punya school of thought, anxiety merupakan satu pengalaman normal, tetapi bila dia jadi berlebihan, dia jadi tidak normal. So in that case, kalau kita dalam Islam kita percaya everything is created with a purpose or with purpose, so apakah fungsi anxiety?
Defense mechanism.
Kita kena, kita berharap.
Biar Aimi jawab.
Okay. In fight and flight situation,
Okay, fight and flight situation.
kita punya mechanism in anxiety.
Okay, so kalau ada fight and flight, maksudnya kita boleh buat apa?
Kita boleh respond well.
Respond appropriate.
Kita boleh respond well to the danger. For example, kalau kita contoh kalau ada danger tu kita boleh respond. For example, kita jumpa pencuri ke, kita terjumpa anjing ke, kita akan ada anxiety and fight and flight. So, jadi kita boleh lari laju, ni kita punya buah lagi cepat, lagi besar, ni kita boleh lari laju.
Right. Okay. So you are arguing from that point, that angle. Anxiety diperlukan untuk kita hidup ataupun respon secara appropriately lah, right? So kalau kita contohnya exam, kita nak exam tetapi kita kurang rasa takut, maka kita tak akan belajar contohnya. Ataupun kalau kita hidup tapi kita tak ada rasa takut, kita akan keep doing the same mistake. Sebab kita tak takut buat salah kan. So we keep doing the same thing again and again. So okay. So your argument based on the purpose of anxiety. So anxiety has a purpose. Right? Lagi, ada tak yang disagree with anxiety? Yang memang rasa macam anxiety tu memang tak sepatutnya ada anxiety ni. Stoicism. You don't attach yourself to anything, and that's the way to detach yourself from emotions, negative emotions. Before this, waktu zaman Aristotle sebelum ni ada falsafah stoicism. Stoic maksudnya they just get detached from emotions semua ni. So ada yang agree anxiety merupakan satu penyakit? Orang kata anxiety, bila kamu anxious, itu bermaksud kamu tidak percaya kepada Tuhan ataupun kamu tidak percaya kepada God's plan. You don't trust You don't trust in God's plan. How would you respond to that? Does it make sense? You are anxious. It means that you don't trust God. Because God Almighty has planned something for you and we believe the end is good, but you are anxious. And it means you don't trust God.
Tak.
Yeah, Khadijah.
Because in our life, there is maksudnya memang tak ada, kita dah ditentukan oleh Allah, tapi dalam kehidupan kita ni kita masih ada pilihan. Maksudnya pilihan tu untuk menjadikan sesuatu tu lebih baik ataupun sama je kalau kita tak buat apa-apa. So contoh macam anxiety tu, masa kita risau untuk present kan, maksudnya kita takut kita present tak baik. So in other way to make our presentation is better, we read more and we search more. So that's how we should apply in our life.
I mean, yeah, okay, I understand your points, but to have the anxiety itself, to be anxious itself, is it a manifestation of distrust in God? Janganlah takut.
I agree with you, Doktor.
Okay, you agree with me? Okay.
Sebab apa? Maksudnya dia tak adalah disagree with God, cuma iman dia tak kuat lah.
Right, iman tak kuat. Right. Okay. Anyone disagree with Amir? Or agree with Amir?
I disagree
Okay, no.
because
Yeah.
it's just that I think some feelings is unavoidable even though we don't want to feel it.
Okay.
So like, okay.
Go on, Noha. Please support for Noha. Are you going to continue, Noha?
And no,
Okay. Right. So you are saying that not everything you can apa? Sorry tadi?
not every feeling you can control.
No, not every feeling you can control. Okay, so if we cannot control feeling, everyone agree with that? We cannot control feeling? Or there is people who can control feeling? Susah lah soalan Tuan Nabil, philosophical. Tak lah, berdasarkan pengalaman korang, 27-29 orang selama 25 tahun ni, 24 tahun ni, pernah tak yang korang berjaya untuk mengawal perasaan masing-masing?
Pernah.
Yes.
Pernah.
Dan sentiasa berjaya?
Not always.
Not always. So ada masa boleh kawal, ada masa tak boleh kawal. Right. Okay. Right. Okay. Menarik. So your argument, you're saying that not everything can be controlled. Tadi Amir cakap dia berkaitan dengan iman sedikit. Right? So kalau imannya tinggi, sepatutnya orang tu tidak ada rasa risau langsung. Betul juga kan kalau Quran cakap wala khaufun alaihim wala hum yahzanun. Is it apakah maksud ayat tu? Mereka tidak takut dan tidak bersedih kan? Anyhow, the point of discussion today is not to get an answer pun. I just want you guys to think about this, because these are the arguments that you're gonna see or you're gonna hear among people out there, even among your patients, among our patients, or even among practitioners, kan? Doctors, Muslim ke non-Muslim, pesakit. So they have their own ideas about having anxiety. And sometimes having the idea about having this anxiety akan mempengaruhi cara mereka mendapatkan rawatan. Sekiranya dia rasa anxiety itu bukan satu masalah, dan dia kata, why should I see a doctor? Kalau saya merasakan anxiety itu merupakan satu masalah iman, instead of seeing a psychiatrist, I would rather see a spiritual healer. Okay? Kalau saya rasa anxiety itu satu benda yang memalukan untuk bercakap sebab dia melambangkan kelemahan, then I would just keep it to myself. Kan? So these are the variability of conception about anxiety that we have in our society, our culture. Okay. though you may find some evidence from your religious ataupun spiritual background yang mungkin inform you about what is anxiety, how to deal with it, and so on and so forth. Right. So for practical reason, in psychiatry, we say, okay, there is a normal anxiety and abnormal anxiety. Let's agree to that. Okay, because kalau we cannot agree on that thing, we cannot move on, we cannot discuss further. So we agreed anxiety can be normal, and they are at certain level it becomes abnormal. So today we're going to discuss about the abnormal part of anxiety, which covers panic disorder, agoraphobia and other phobias, obsessive compulsive disorder, and generalized anxiety disorder. Before we proceed, let's discuss the definition of phobia. Okay, when we say phobia, what do we mean? Aku phobia tu jumpa dia. Kan? Aku trauma tu. Trauma jumpa dia, trauma.
It's like
Scared.
extreme or marked fear against a situation, or it can be some objects or animals.
Okay, so extreme. The key word there is extreme fear towards
Yes.
a person ataupun an object or a situation. Okay, thank you, Faisha. Tell me more. Tell me 3 other criteria for phobia. Bayangkan benda yang korang phobia, cicak ke, lipas ke, right? Politician ke, whatever lah. Bayangkan that object and that subject. What are the things that you learn about the subject other than extreme fear?
Other than that, the thing that that every time I encounter my phobia, I will avoid it.
Okay.
And I will always have the anxiety or the fear or the distress.
Oh, okay. So the other one is, it is often treated with avoidance. Okay. People would avoid it because of that extreme fear. Okay. Apa lagi satu about the fear itself, other than its extreme ataupun its excessive? What about the thought related to that object ataupun that situation?
Out of proportion.
Okay, out of proportion, and the fear itself is
irrational fear.
so irrational. Okay, excessive, out of proportion, irrational, avoidant. It's treated with avoidant, or intense anxiety kalau kita expose benda tu. So those are the 3 or 4 cardinal features of phobia. So you must remember this. Phobia 1, 2, 3, 4. And that can be applied to any other phobias like agoraphobia, specific phobia, social anxiety disorder. Okay. Now, having that defined, can we have the presenter to talk or elaborate further about phobia? Siapa present phobia?
Me, Doctor.
Ya, Noha. Okay.
So, I should present my slide kan?
You can. Kalau you tak guna slide pun tak apa, you nak guna slide pun tak apa. You can share your slide with the rest. Yeah.
So, okay. Bismillah. Phobia, as Dr. and also we discussed just now, it refers to an excessive fear or marked or intense fear towards an object, situation, or circumstances. So this also has been mentioned by the doctor. So fear and anxiety, fear can be normal or abnormal. In phobia, the fear is pathological because it is maladaptive or inappropriate to the stimulus. So as Dr. mentioned, the cardinal features, the patient have a marked, can you guys see my slide?
Yes.
Okay. Sorry. So they have marked fear or anxiety towards a stimulus. Because of this fear, they tend to avoid the stimulus. If they are unable to avoid the stimulus, they will endure or face the stimulus with intense fear or anxiety, and this may be displayed as anger or irritability. So there are three types of phobia: agoraphobia, specific phobia, and social phobia. So for agoraphobia, it comes from the word agora, marketplace, phobos, which means fear of. So it's not a fear of a marketplace, but instead agoraphobia is a fear of or anxiety regarding places from which escape might be difficult. So it is the most disabling phobia because the patient tends to stay at home only, and it often coexists with panic disorder. The theory is initially the patient had underlying panic disorder. So because of the history of panic attacks in the public places, so patient develop fear when they are in public places because they're afraid they're unable to find escape or help if they develop panic attacks in that situation. Okay, so epidemiology lifetime prevalence is 2 to 6%. So generally, they have intense fear in the crowded places because fear of unable to escape or find help. So they tend to stay at home only. If they need to go out, usually they will need a companion, or almost always they need to bring their mobile phone to easily call for help. Okay, so for the diagnosis, this is from the DSM-5. Okay, criteria A, the fear, there is a marked fear or anxiety about 2 or more of the following 5 situations. So there must be at least 2, because if one only, it might be a suggestive of specific phobia instead of agoraphobia. So these 5 situations here are all the situations where the patient find it difficult to escape. Okay, so B, the criteria, the individual fears or avoid this situation because of the thoughts that escape might be difficult or help might not be available. Next, the situation almost always provoke fear or anxiety. Criteria D, the situation are actively avoided, require the presence of companion or end up in intense fear or anxiety. Next, the fear or anxiety is out of proportion to the actual danger. And these symptoms is persistent for at least 6 months. So it's not really episodic, it must occur throughout the 6 months. Next criteria, the fear, anxiety or avoidance causes clinically significant distress or impairment. If another medical condition present, the symptoms is clearly excessive. Okay, and then last criteria, the fear, anxiety, or avoidance is not better explained by symptoms of another mental disorder, such as the differential diagnosis.
Right. So can
Okay.
Nuha, can you summarize what you understand in your own words? What agoraphobia is?
So agoraphobia is a fear of
Okay, pergi
being
ke,
in places
sorry, pergi ke
where
sebelum ni. Okay, look at no, the second one.
okay.
Next slide. Right. Look at those five places. What do you understand about those 5 places?
Basically the places is outside of the patient norm. They perceive it as unsafe places because they couldn't find
Hmm.
an escape dengan cepat.
Hmm. Dalam dunia ni, kat tempat mana yang kita rasa selalu selamat?
Rumah.
So, di rumah.
Rumah.
Di rumah. Rumah siapa? Rumah kita ke rumah makcik ke rumah kawan?
Rumah sendiri.
Rumah sendiri.
Rumah sendiri. Kenapa bukan rumah kawan? Bukan rumah makcik?
Sebab
Tak
tak
familiar.
Kita tak
familiar.
familiar.
Tak familiar. So, GIS dia ialah?
Unfamiliar place.
Right. So, those 5 places are unfamiliar places to the patient. But for the sake of exam, you have to remember those 5 places. Right. But the gist is to be in a place where the patient is not familiar with, where escape or help may not be accessible. Sebab dia tak familiar. Tak tahu pintu kat mana, nak lari kat mana, nak ambil taksi kalau nak ke hospital kat mana. So that kind of fear that the patient has. And the fear is about what? Let's say the patient is in a mall, so risau dia apa? Tak dapat bantuan, tak dapat escape dari apa?
Situasi ramai orang.
Okey, ramai orang itu satu keadaan, tetapi ketakutan dia apa?
Tak dapat lari dari bahaya, danger.
Look at B. Developing panic-like symptoms. In case patient develop panic-like symptoms. Dia pergi ke mall, risau dia, in case aku develop panic-like symptoms ataupun panic attack, dan waktu tu tak ada siapa boleh tolong. Ataupun waktu tu tak boleh nak escape. Ataupun setengah orang tak risau tentang panic attack, tetapi dia risau kot pergi ke mall ni tak lagi nak terpengsan ataupun rasa macam fear of incontinence, right? So benda-benda yang memalukan berlaku di luar. Okay, itu kerisauan dia. Kerisauan dia takut kalau escape ataupun help tu tak dapat, in case panic attack berlaku ataupun benda-benda lain yang buruk berlaku dekat luar. So that's the gist. Dan benda ni, those places provoke anxiety and often treated with avoidance. Dan it is not better explained by other anxiety disorder. Contohnya macam social anxiety disorder. Nanti we're gonna learn about social anxiety later. Any question about agoraphobia?
So in essence sebenarnya dia takut dengan tempat tu, dengan lagi satu dia takut yang dia akan develop panic like symptom yang anxiety tu lah.
Dia takut dia develop panic like symptoms and benda-benda yang menakutkan tu di tempat-tempat berkenaan.
Oh, okay.
Doctor,
Yeah.
if patient is accompanied by the companion, so do they still have the fear or not?
Look at next slide. No, sorry, sebelum tadi. Companion, presence of a companion are actively avoided or required presence of companion. Okay, so that is one of the criteria. So bila kita di-exposekan dengan benda tu, sama ada kita lari, orang ajak kita keluar, kita tak nak pergi, kita duduk kat rumah, tak nak pergi, ataupun kita keluar dengan someone else, ataupun keluar dengan ubat, kena bawa ubat spare, ataupun kita pergi je lah, harung je lah, tapi dengan intense anxiety. Okay.
Doktor, nak tanya yang pasal ada perkataan note dekat next slide. Yang pasal irrespective of presence of panic disorder tu macam mana tak aku faham. Yang ni, agoraphobia is diagnosed irrespective of the presence of panic disorder.
Oh, okay. So last time in DSM-4, now kita guna DSM-5. In DSM-4, agoraphobia cannot stand as a diagnosis. So agoraphobia only stand as a diagnosis along with panic disorder. So you kena cakap macam ni, patient has panic disorder with or without agoraphobia. But now, agoraphobia is a diagnosis itself. Okay, so you can diagnose a person agoraphobia tanpa ada panic disorder. Okay, next.
Okay, for the management, it can be divided into pharmacotherapy or psychotherapy. So we can give benzodiazepine or SSRI, which is the first line in treating panic disorder because most of the patient has underlying panic disorder. We can also give tricyclic and tetracyclic drug. For the psychotherapy, there are many types of therapy. The supportive, insight-oriented, cognitive or visual. Later, I will explain more on behavior and virtual therapy because I think, if I'm not mistaken, these are more common use therapy for phobic disorder.
For what? What disorder, sorry?
Phobia, as general.
Which one?
Doctor.
Tak, which one is used?
All.
All, alright.
Behavior and virtual.
Right.
Behavior and virtual therapy for all types of phobia.
Right. Okay, so for pharmacotherapy, you use SSRI as the first line. So under SSRI, you have a few options. You have sertraline, you have escitalopram, you have fluvoxamine, you have fluoxetine, you have paroxetine. So those are the options that we have. And then we can also use benzodiazepine as an adjunct to SSRI. So read about these two medications, when to use SSRI sahaja and when to use SSRI with benzodiazepine. And if we were to use benzodiazepine for phobia, agoraphobia, what type of benzodiazepine? Short acting, long acting, intermediate acting? Which one? As for psychotherapy, kalau korang rasa lah korang kan dah biasa ada perasaan takut ni kan. So macam mana nak merawat perasaan takut? Apa dia? Tak dengar. Macam mana? Takut exam kan? Exam. Takut lah exam.
Expose. Biasakan.
Apa dia? Biasakan.
Sebab kognitif.
Aimi cakap
Train mind. Kita train mindset. We have to train mindset in cognitive punya terapi. For example, we have to say to ourselves, this is only an exam, this is not the end of the life. So just train our mindset.
Right, okay. So itu contoh pendekatan kognitif. Terima kasih. Bukan kognitif pula macam mana? Noha?
Exposure.
Exposure tu macam mana?
Kita exposekan diri kita banyak kali dengan stimulus tu supaya lama-lama macam kita biasakan diri, lepas tu kita tak ada dah rasa takut tu.
Right. So untuk fobia kita gunakan systematic desensitization. Right, systematic desensitization yang mana we assess patients punya fear and then kita try buat hierarchy of fear lah, macam pyramid of fear. Yang atas tu yang paling takut, the tip of pyramid is the most fearful thing to do by the subject, and the base is the least fear. So kalau dia kata kerisauan dia agoraphobia, takutnya untuk berada dalam mall. So yang bawah sekali, yang atas sekali tu berada dalam mall seorang-seorang. Mungkin bawah sikit daripada tu takut dia apa? Mungkin berada dalam mall dengan someone else. Ataupun berada di luar mall. Right? Bawah lagi daripada tu, naik kereta ke mall. Lagi bawah lagi, duduk di rumah dan plan nak pergi ke mall. So we get that hierarchy of fear and arrange them according to the hierarchy. And we must expose the person with the least one, okay, towards the highest. So we're gonna expose the patient for, let's say, 30 minutes for the first one, and then we do it repeatedly until the patient is okay to overcome that fear. We move to the next stage, and then any settle, we move to the next stage. So that is systematic desensitization. And at the same time, we can also incorporate cognitive intervention dekat situ lah. So after kita dah buat eksperimen tadi tu, expose dia tu, so we discuss with the patient, how do you feel, and then what happened, waktu you takut tu apa, what kind of thoughts that pass through your mind, and now after this thing settle, how do you feel, what kind of thought you have now, did it do any harm, so that kind of stuff. Okay, so that kind of stuff yang bersifat kognitif. Yeah, so that is macam briefly about systematic desensitization and also cognitive approach to phobia, agoraphobia. Any question? Okay, next. Tulisan.
Okay. These are the differential, and particularly for prognosis, it is poor in agoraphobia without history of panic disorder, agoraphobia with depressive disorder, and also those with alcohol dependence. Let's move on to specific phobia. So it is a strong, persisting fear of an object or situation. The patient may not directly say that they have fear of a specific object, but instead they anticipate harm Okay, for example, like actually they fear of dog, so the anticipate harm is the getting bitten by the dog, or they may panic at the thought of losing control. So for example, they fear of elevator, so they may worry that they will faint when they get pengsan when they get in the elevator. So it occurs in about 5 to 10% of the population. It is the most common mental disorder among women and the second most common among men. So there are actually five major specific phobia categories, which are fear to natural environment, fear to animals, fear to medical treatment, fear to situation, and another types is others, as according to DSM-5. Others mean basically stimulus other than these four categories. Okay. So according to the
Noha, dia lebih kurang sama sahaja dengan anxiety, dengan agoraphobia. Just substitute object tu dengan specific item lah. So the rest are more or less the same. I think it's self-explanatory, boleh baca sendiri dekat situ. Cuba tengok next slide. Okay, lagi. Rawatan pun lebih kurang sama, cumanya specific phobia is the easiest type of phobia to be treated. Usually we don't require medication for this, just simple exposure therapy. Alright, next.
So next is social phobia, or also known as social anxiety disorder. It is a fear of social situation, including situation that involves scrutiny or assessment or contact with stranger. So patient may have fearful of embarrassing themselves patient actually fear of embarrassing themselves in the social situation. They may have fears about performing specific activities. They may experience a vague non-specific fear of embarrassing oneself. So the fear is not the environment. The fear is not to the situation itself, but it must be actually the embarrassment that may occur in the situation. So according to this, there is a marked fear or anxiety, at least one, in social situation in which the individual is exposed to possible scrutinies by others. So the example, having a conversation, meeting unfamiliar people, being observed and performing in front of others. These are the situation where there is a possibility that, or at least the patient perceive that the other people will scrutinize him or her. Okay, and this, the cognitive is that the individual fears that he or she will act in a way or show anxiety symptoms that will be negatively evaluated, such as will be humiliating or embarrassing, or it will lead to rejection or offend the others. So this the same like other phobia. It is also avoided the same, and then the fear is inappropriate to the actual threat, and typically at least occur for 6 months. Also the same. Okay, and if there is another medical condition, the fear is clearly unrelated or excessive. So meaning that because this kind of disease, this example of this disease, Parkinson disease, obesity, disfigurement for burns or injury can exacerbate because like they perceive that they are more prone to be evaluated from others because this disfigurement is like very apparent.
Okay,
So
what's the difference between agoraphobia and specific and SAD, social anxiety?
social anxiety and agoraphobia. So the agoraphobia is about himself, fear of finding escape or unable to find help. But in social phobia, it's more to if the patient feel that he or she will embrace himself.
Tadi dekat agoraphobia pun ada benda-benda yang menakutkan kan, ataupun benda-benda yang memalukan. Tapi fear-nya lebih kepada getting help ataupun escape from that situation. In social anxiety, it's more of fear of negative evaluation of other people, fear of people's perception. Whenever you perform something, or whenever you be in a situation where you are being observed, or in a situation where you are in a social situation, and you are afraid of being negatively judged by other people. You are on the stage and then you exhibit a few anxiety symptoms, tremors, shaky, suara ketar-ketar. Your focus is on what other people would say or what other people would think, and that causes your anxiety to be more. So that is, if it is avoided, if it is excessive, if it persisted for 6 months, then it's social anxiety. Okay, so this condition is also treated with medication, SSRI or benzodiazepine, and with psychotherapy, like I've mentioned just now. Any
So
questions?
basically, the social phobia, it has the other person punya factor lah.
It's all about you. It's all about us.
Okay.
I mean, your perception about other people. Okay. Teruskan.
Okay, thank you.
Welcome. Next.
This basically are the difference. There are also any difference. So a little bit on behavior therapy, but the doctor also mentioned.
Yep. Go to other diagnosis. Siapa lagi nak present?
Oh, okay.
Right. Okay, before we go to OCD, let's discuss about what do we mean by obsession. Obsesi.
Repetitive thoughts.
Dalam bahasa Melayu, obsesi. Thank you, sister. Obsess.
Tergila-gila.
Gila-gila obsess. Okay, lagi.
Mahukan sesuatu.
Apa dia?
Mahukan sesuatu ada.
Mahukan sesuatu Ya. So kefahaman kita tentang obsesi dalam bahasa tidak sama dengan apa yang dimaksudkan dengan obsession in psychiatry lah. Okay. So in obsession and compulsion, obsession is about you having recurrent thoughts. You having recurrent thoughts ataupun images ataupun urges. So dia ada 3 benda kat situ. Thought ataupun fikiran ataupun gambaran ataupun desakan dalaman. urge, which is intrusive. Ya, intrusive ni maksudnya fikiran yang berulang-ulang yang datang secara tiba-tiba, yang tidak boleh dikawal, it's difficult to control, intrusive, and kebanyakan masa menyebabkan distress, menyebabkan rasa tak senang duduk. Kenapa? Kenapa rasa tak senang duduk?
Sebab dia intrusif.
Selain daripada dia intrusif, apa lagi yang menyebabkan kita tak senang duduk? Banyak benda yang berlaku dalam hidup kita sekarang ni, apa benda yang menyebabkan benda-benda yang menyebabkan kita rasa restless kan dalam hidup ni? Apa benda? Apa gist dia? Benda-benda yang menyebabkan kita tak happy ataupun tak senang duduk ni?
Benda yang kita tak nak buat.
Benda yang kita tak nak buat. So things that go against our value, things that go against our will. So dalam obsession, contohnya saya seorang Muslim, tetapi saya ada fikiran yang berulang-ulang yang datang secara tiba-tiba yang tidak boleh dikawal tentang gambar someone nude contohnya, gambar bogel contohnya kan. So saya tak nak benda tu. Saya tahu benda tu berdosa untuk ada that kind of thought ataupun that kind of images. I believe that way. So tiba-tiba gambar macam tu datang. Berulang-ulang pula tu, bagi I yang jadi benda tu macam I rasa ini mesti salah aku. Sebab kenapa benda ni datang berulang-ulang? Ini mesti setan contohnya. Jadi aku tak suka benda tu sebab benda tu go against my value kan, my beliefs. So that is obsession. Okay, itu kalau dalam bentuk agama. Kalau dalam bentuk yang bukan agama, let's say you value precision ataupun you value you value precision. So anything that ataupun you value hygiene kan, you value safety. So you basuh tangan banyak-banyak kali bila you pegang something else, pegang tombol ke, pegang meja ke, benda-benda yang ada potensi untuk bagi jangkitan. So you cannot accept the risk to get infected. Okay? And then doubt tu datang dalam bentuk fikiran ataupun gambaran. Fikiran contohnya macam tangan kau kotor. Right? Fikiran tu datang bentuk macam tu, tangan kau kotor. Kalau tak basuh nanti kau sakit contohnya kan. Itu kalau kita boleh cakap lah fikiran kita. Kebanyakan masa fikiran kita datang macam zup, kita terus faham kan. We don't explain, we don't have to explain our thoughts kan. Tapi kadang-kala fikiran itu datang dalam bentuk suara. So sometimes orang confused, am I hearing voices or it's actually my thought? So that's why OCD, one of the differential is schizophrenia. Some people have difficulties to differentiate whether this is thought or this is actually voices coming from outside. So one of the differential of OCD is schizophrenia. So that is obsession. Compulsion is what you need to do. Okay, more often than not, compulsion is what you feel compulsed to do in response to obsession. So now I have these thoughts about these images kan, these tasteful images yang I rasa macam dia menyebabkan aku berdosa. So in order to reduce this, I have to compulsively recite A'udzubillah. Okay, for just to reduce that anxiety or just to get rid of those images. And the nature of compulsion ialah dia ini it's usually there is no logical way, okay, that connects between the two. There is no logical way to connect between the two, between obsession and compulsion. And the aim is to cancel off the obsession. Okay, contohnya orang yang ada obsession tentang tangan dia kotor tadi tu, dia compulsion dia kena basuh tangan. Dan kadang-kadang bila dah basuh tangan, dia masih doubt lagi, tangan aku bersih ke tak bersih. So dia basuh lagi. Faham ke? So obsession, OCD, nak diagnose orang untuk OCD, dia boleh ada obsession sahaja tanpa compulsion ataupun compulsion saja tanpa obsession. So you can read dalam compulsion, ada one paragraph, ada one clause there says that the compulsive act must be done or must be performed based on certain rigid it must be applied rigidly. Dalam DSM tu ada tulis compulsion tu it must be applied rigidly. Sometimes compulsion tidak ada obsession. Dia just rasa ada urge untuk buat compulsion tu without any obsession. So just accept as it is lah. It can be difficult to explain now. Maybe once you see the patient then you can appreciate better. So dia ada banyak tema dalam obsession dan compulsion. Ada tema berkaitan tentang kebersihan, ada tema berkaitan tentang simetri, ada tema berkaitan dengan keselamatan ataupun harm. You know, I have obsession of harming other people. Mak yang baru lahirkan baby, dia rasa macam ada obsession macam nak suffocate, macam nak strangle the baby. The mother loves the baby, but your thoughts, dalam your mind keluar that thoughts yang macam, oh, it's good to harm your baby. But patient tak rasa benda tu betul dan menarik. Dan dia terpaksa, compulsion dia lah mungkin dia simpan semua pisau-pisau dia ataupun dia kena check anak dia dah mati ke belum. So that kind of reaction that the patient do.
Doktor.
Ya, nampaknya ramai orang yang menarik tentang OCD. Ya.
The one example that you just gave about the mother have a feeling to killing the child, how does it differs from the postpartum psychosis?
So you have to know psychosis, hearing voices is hallucination is you dengar suara dia macam suara saya, jelas yang you dengar di kedua belah telinga you, dia datang daripada luar, dia bukan sebahagian daripada diri you. So that is hallucination. Thoughts, recurrent intrusive thought is thoughts, it's here, dalam ni. Ini memang fikiran saya, doktor. Fikiran saya, tetapi dia tidak boleh dikawal, doktor. Susah, dia berulang-ulang, doktor. Dan saya tak suka fikiran ni, doktor. Tapi kenapa dia ada, doktor? Tolonglah, doktor. Right? So that is...
Thank you, doktor.
Yeah. Farisha?
Alright, thank you, doktor.
Welcome. Okay. Iz nak tanya soalan?
So yang harm yang tadi tu, example tu, dia sama dengan intrusive thoughts lah. I mean,
saya sayang anak saya. So usually kan, obsession ni, dia berlaku pada benda yang kita paling sayang sekali. Benda yang kita suka. Benda yang kita tak boleh nak lepaskan. Macam orang yang ada obsession tentang religion tu, korang akan perasan orang-orang yang was-was tentang agama ni adalah mereka-mereka yang selalu sembahyang, selalu pakai kepiah, pergi masjid. So they value that thing very much. But they have the genetic. So the thought comes in the form of things yang go against their value. So mak yang sayangkan anak, tiba-tiba ada fikiran macam, aku tadi hantar anak aku, baby kat belakang tu dah ambil belum? Ke tertinggalan kereta sekarang? Kan banyak kan kes baby tinggalan kereta mati kan? So mak ada fikiran macam tu. Sebab apa dia sayangkan anak dia? Tapi dia ada that intrusion yang doubt, yang kau mungkin tertinggal anak kau. So terpaksa lah berlari-lari pergi check. Sekiranya benda tu berlaku berulang-ulang dan mengganggu kerja dia, cukup certain duration, ambil masa pula tu, then we call it OCD. Berkerut semua muka. Kenapalah manusia ni kompleks?
Doktor, I have a question. So OCD ni adakah kita boleh samakan dengan was-was?
Was-was dengan OCD?
Maksudnya OCD ni sama erti dengan was-was. Macam in term of agama tadi tu, dia macam tu lah. Dia macam tak.
Right, OCD sama dengan was-was. Okay. Siapa pernah ada was-was? Ambil sembahyang rasa macam dah ambil ke belum ni? Ataupun dah sembahyang rakaat kedua rasa dah macam tak cukup satu lagi. Siapa ada benda tu?
Pernah.
Semua ada kan? So was-was, was-was ni satu fenomena yang kena pada semua orang. Kena pada semua orang, baik sakit ataupun tidak, baik Muslim ataupun tidak. Was-was dalam arti kata yang asal, kalau dalam kitab-kitab Imam Al-Ghazali, dia merujuk kepada bisikan, merujuk kepada negative thoughts. Okay, negative thoughts. So every one of us here, we are actually vulnerable. We are exposed to that kind of negative thoughts. So itu istilah asal was-wasah. Negative thoughts, fleeting negative thoughts yang ada dalam fikiran. Yang asalnya daripada syaitan lah. Kalau kita ada positive thoughts in our mind, it can be part of ourselves or it can be from malaikat. Kita panggil ilham. Kalau negative thoughts daripada diri kita sendiri ataupun daripada luar, daripada syaitan. So kalau kita attach to that negative thoughts, our action will be negative. Kalau we entertain that positive thoughts, the outcome will be positive. So that's how Imam Al-Ghazali described the process of thoughts leading to action. And that's why intention is very much important in Islam. Or in every act pun. Tapi bila kita cakap pasal OCD ni, it's actually about a pathological one. Okay. So kalau dalam bahasa Arab tu dia panggil al-waswasah al-qahri. Okay. Al-waswasah al-qahri. So dia tidak sama dengan was-was yang orang lain biasa tadi tu. Dia jadi sukar untuk dikawal, berulang-ulang, tak boleh kerja dan sebagainya. So it's not the same, tetapi dalam masyarakat setengah orang guna was-was merujuk kepada OCD. So kita kena accept that differences in society.
Thank you.
Okay, Iz, aku dah tolong banyak ni.
Banyak.
Nak tanya yang pasal kalau yang seagama tu, kalau dia was-was sampai dia ambil wuduk banyak kali dan solat banyak kali tu tak kira OCD ke?
Kalau dia kentut banyak kali,
yang dia tak kentut, dia kata macam dia punya wuduk tu macam rasa tak sempurna. So dia sampai kena ambil wuduk banyak kali dan solat banyak kali. Tu tak kira OCD was-was tu.
Kalau macam tu, dia kira OCD lah. Kalau there is no evidence to suggest yang wuduknya dah batal, dia tak dengar bunyi, dia tak ada bau, tak ada kesan apa-apa, dan tiba-tiba dia rasa, aku tak yakin lah, kan, tak yakin wuduk aku ni ada lagi. Mungkin keluar tapi aku tak dengar. Right, mungkin hidung aku sumbat, aku tak tahu. So I have to take wuduk again. Dah ambil wuduk rasa tak sempurna, kena ambil lagi. Dan you must establish that thoughts in the mind. Yang it is intrusive, it is distressing, it is recurrent, you cannot control, you must establish that symptoms. Then you say this is was-was. OCD. So, kenapa saya tak sebut agama tu sebagai satu tema? Sebab agama tu bukan satu tema, agama tu satu macam just colour the symptoms sahaja. Dalam ritual tu sendiri, kalau agama dia berkaitan tentang doubt ataupun hygiene. Tadi sebut pasal hygiene kan, contamination, hygiene semua tu, itu tema. Ataupun symmetry. So itu tema. Agama tu satu just a culture, satu budaya yang mewarnakan dia punya gejala tu.
Faham.
Okay, next.
Okay, so basically doctor has already defined what is obsession and also compulsion. So next, so basically this is what doctor has explained before. Next, so it's recurrent obsession or compulsion causing severe distress, time consuming and interferes significantly with the person's normal routine, occupational functioning, social activities and also relationships. Next. So for epidemiology, next, the prevalence of the OCD is 2 to 3% of the general population. Next thing, 2 to 3% of general population, and it's the fourth most common psychiatric diagnosis after phobias, substance-related disorders, and major depressive disorder. And male is have equal chance with female to get OCD in adults, but as for adolescent, males are more commonly affected rather than females. And as for single person, they are more affected than married, although this finding reflects the difficulty that a person with OCD might have in maintaining a relationship. So that may cause the patient with OCD to have more single. Next is these are the common comorbidities that are associated with OCD. So the most common is major depressive disorder, which is about 67%, followed by social phobia, which is 25%. So other common comorbid psychiatry diagnosis in patients with OCD includes alcohol use disorder, generalized anxiety disorder, specific phobia, panic disorder, eating disorders, and personality disorders, and Tourette's. So incidence of Tourette's in patients with OCD is around 5 to 7%. Next, so these are the common forms of OCD. So there are obsessions and also compulsions. So what Ms. Doctor had said before, for the major themes, that actually for contamination, pathological doubt, intrusive thoughts, and symmetry. So for the most common pattern is contamination. Usually they are fear of contaminated objects, so they will follow by a compulsive act, which is washing. So they fear that an object is contaminated. Usually like germs, dust, so they will do it repetitively. And for pathological doubt, they have obsession of having doubt, so usually followed by compulsion of checking. So obsession may involve multiple times of checking. And for intrusive thoughts, this is the same as what Doctor had said before, like the harm. So they have repetitious thoughts of aggression or sexual thoughts. So in order to relieve that obsession, they may report this act. They may report the thought to the police themselves because of these aggressive and sexual thoughts. So when they have fear, they report to the police. They may report. So next is symmetry. So for symmetry, they may have a need for symmetry or precision. So in order to relieve that, they may take hours to do something, like to eat a meal or to shave their facial hairs, maybe. So they take time. So the compulsion is actually slowness. They do it precisely and symmetrically. Okay, next. So this is the diagnostic criteria of obsessive and compulsive disorder, DSM-5. So next is the summary of the DSM-5 criteria. So the first criteria is having either obsession, compulsion, or both. And for criteria B, it must be time consuming for more than 1 hour per day, or having significant distress to the person or having social impairment. And the next criteria is it shouldn't be related to, it shouldn't be substance related and not attributable to any medical condition. And the last criteria is not better explained by another mental disorder. Okay, next. So as part of the diagnostic criteria, the DSM-5 also allows to indicate whether patient's OCD is characterized by good or fair insight, poor insight, or absent insight. So basically, good insight meaning that they recognize the OCD beliefs are probably not true. That's for good. And for poor insight, they believe that OCD beliefs are probably true. And for absent insight, the patient is already convinced that the belief is true. So poor is good is probably not true. They think that it's probably not true. Poor, probably true. Absent is they are already convinced. So you also need to specify if the individual has current or past history of tic-related disorders such as Tourette's. Next. So this is the management. So in treatment, there are well-controlled studies that have been found is that pharmacotherapy, behavior therapy, or both are effective in reducing the symptoms of patients with OCD. So pharmacotherapy, the standard approach is to start with treatment with SSRI for 8 to 16 weeks. So this is the first line. Or you can also use clomiparin. But clomiparin have longer side effects and more troubling as compared with SSRI. So they are actually having the best outcome when combined with behavior therapy, which is the exposure and response prevention. So basically, exposure and response prevention is actually a therapy that encourages you to face your fears and let the obsessive thoughts occur without doing any compulsion. That's actually the exposure and response prevention. And they also can do cognitive therapy and also supportive psychotherapy. As for electroconvulsive therapy, it's not used as a first-line treatment. However, several reports that they say that it's effective for severe OCD, especially when the first line is failed. And for psychosurgery, it's used to relieve the symptoms of OCD which does not respond to medications or behavioral therapy. So in psychosurgery, they do cingulotomy. Cingulotomy is I'm not sure about cingulotomy, but
okay. We don't do any surgery anymore now.
Oh, okay.
Okay, unless you tengok cerita Ratchet ke, ataupun you tengok cerita apa? Shutter Island ke, adalah scene tu dah lama cerita historical punya scene. Anyhow, nowadays we move to something yang invasive, like deep brain stimulation. Okay, it's a center like USM, HUSM. They have a strong and big neurosurgery group. So they do deep brain stimulation. So deep brain stimulation can be used for OCD as well as for Parkinson, severe Parkinson. So read on DBS, deep brain stimulation.
Okay, Doctor. Thank you.
And We don't use ECT for OCD. We only use ECT kalau dia ada comorbids like depression.
Okay. Alright, okay. Thank you. Next.
Tanik. Tanik.
Sorry, Doktor.
Saya nak orang yang present panic untuk present.
Maksudnya?
Maksudnya awak berhenti kat situ lah, tak payahlah present dah.
Okay.
Okay, Assalamualaikum warahmatullahi wabarakatuh. So I will present about the panic disorder. So first the definition. So next. So it is an acute intense attack of anxiety that accompanied by the feelings of impending doom. So it is characterized by the discrete period of intense fear, and it can be vary from several attacks during one day to only a few attacks during a year. Okay, next. So for the epidemiology, so the lifetime prevalence of the panic disorder is 1 to 4% range, and then it is the mean age of presentation is 25 years old, but it can develop at any age, and women 2 to 3 times higher or more likely to be affected than men, and then the only social factor that identified to contribute to the development of panic disorder is due to recent history of divorce or separation. Okay, next. So for the etiology, it can be divided into biological and also psychosocial. So for the biological, first is the genetic factors. When the first degree relative of patient with panic disorder have 4 to 8 times higher fall to have panic disorder compared to other relative of other psychiatric problems. And then the next monozygotic twin also have higher chance to have a panic disorder compared to the other twin. Okay. And then the next one is the premorbid personality, such as anxious and worried, low self-esteem, poor coping skill, and when perfectionist or highly obsessional, so they can have higher risk to have panic disorder. The next one is the biological changes that lead to the abnormality in the brain structure and also function. So for example, is serotonin. When the serotonergic dysfunction can increase rate of anxiety, while for the GABA, when there is a local inhibitory of the GABA transmission, it can elicit anxiety-like physiological symptoms. And then for the noradrenaline, that when there is abnormal regulation of the brain noradrenergic system, so it also can elicit the anxiety symptoms. Same goes with the changes in next one is the panic-inducing substance. So for the panic-inducing substance, we call as a panicogen. So it can be either respiratory, neurochemical, or isoproterenol. So for the respiratory, such as carbon dioxide or sodium lactate and bicarbonate. So when there is when these three things cause respiratory stimulation, and then it can cause a shift in the acid-base balance that later on lead to the anxiety. The next one, there is a changes in the brain structure. So for example, from the MRI, there is a cortical atrophy in the temporal lobe, and then while for the PET scan, there is a dysregulation of the cerebral blood flow, that which can lead to the vasoconstriction and then lead to the CNS symptoms such as dizziness and also peripheral nervous system symptoms, the symptoms of the peripheral nervous symptoms. Okay, so the next one is the psychosocial. So for the psychosocial, it is triggered by the having higher stressful life event or greater distress. So for example, when the patient have a protective parents or when the upbringing is chaotic and also uncertain environment. The next one is when the childhood, when the patient has childhood trauma or history of separation anxiety. And then the next one is a loss of loved one and when there is a family, marital or work problem. So next. So for the diagnostic criteria, first, when there is a recurrent, unexpected panic attack. So panic attack is a abrupt surge of intense fear or intense discomfort that reach peaks within minutes and during which time four or more of the following 13 symptoms occurs. So the symptoms can be either from the cardiovascular severe symptoms such as palpitation or chest pain, respiratory such as SOB or choking, from the abnormal such as nausea, and then CNS such as dizziness and paresthesia. So for the peripheries, the patient can come with sweating, trembling, chills or heat. Okay, next. So for the next criteria is at least one of the attacks have been followed by 1 month of the following. So the first one is when there is a persistent concern about the attacks or the consequences. Then change behavior that to the attack. Okay, such as when the behavior designed to avoid having panic attack or such as avoidance of the exercise or unfamiliar situation. Next. Okay, so for the next criteria is this disturbance is not attributable to the physiological effect of a substance such as or medication or any other medical condition, and then the disturbance is not better explained by another mental disorder such mental anxiety that have been classified society or specific phobia. Okay, next. So for the differential diagnosis of the panic disorder, we can anxiety secondary to the medical causes, in which it can be from the cardiovascular disease, pulmonary disease, endocrine disease or neurological disease. And then for the second one is when the anxiety secondary to substance or medication. So for the substance, it can be either intoxication or withdrawal. And then the next one is when the anxiety secondary to the psychiatric disorder. So the psychiatric disorder, particularly other anxiety disorders such as social phobia, agoraphobia, GAD, and also separation anxiety disorder. So next. So for the investigation, we can divide it into three: biological, psychosocial, and also spiritual. So for the biological, of course, a baseline such as full blood count, renal profile, and also LFT. And then the next one is a urine toxicology, thyroid function test, and also ECG. So basically for the urine toxicology, it's to check whether there is any drugs intoxication or thyroid function test for any hypothyroidism or hyperthyroidism, and ECG is for the cardiac problem. And then for the psychosocial is first we take a collateral history from the family, friends, colleague, and also attending GP. We can also trace the patient old notes, such as we can look at the previous symptoms, investigation, medication, and also side effects. And then the next one is a home visit by doing the social background or by assess their family support. And other than that, we can look at their academic or work report and assessment of the anxiety and depression by using back anxiety inventory or even Hamilton inventory rating scales. And then the next one is the assess the patient coping mechanism. Okay, so for this spiritual, we assess the patient knowledge, attitude, and practice with regard to their religious practice. Okay, next. So for the treatment, we can also divide it into three: pharmacotherapy, physiological, and also spiritual. Okay, next. So for the pharmacotherapy, So this is an example of the drugs that are available for the panic disorders. So for the all SSRI, so all SSRI are effective for the panic disorders, and then the onset of the anxiolytic is longer than antidepressive effects. And then for the paroxetine and paroxetine CR, so it have sedative effect and also tends to calm the patient immediately. While TCA, which is tricyclide, and tetracycline TCA, which is chlormipramine, also have a superior experience for the panic disorder compared to the benzodiazepine and also monoamine oxidase inhibitor. But benzodiazepine usually used during acute phase, infrequent, persistent, and also severe attacks because it has a most rapid onset of action. And then duration of the drugs is basically when the drug have become effective, so we can continue the pharmacological treatment for about 8 to 12 months. Okay, next. The next one is a physiological. So by giving psychoeducation, we educate the patient about their illness and treatment, and we explain about the panic attack itself. And then the next one is the cognitive and behavioral therapy. Is by giving the behavioral modification, modify and correct their misconception, and then change the way they perceive the event. And then the next one is the CBT, when there is a combination of the CBT and also pharmacotherapy, it is more effective than mono treatment. Okay, the next one is stress management and also relaxation and deep breathing. So it can reduce the symptoms. Same goes with the lifestyle changes such as healthy eating, exercise, and also good sleep. So next. So the last one is the spiritual. So it can be depend on the individual insight and perception toward their religious. So we implement the implementation of the religious obligation and understanding the meaning of each act. And then interaction with positive environment such as mix with good and also positive people. So the last one is the prognosis. Next. So in terms of long-term follow-up, so 30 to 40% of patients can have symptoms-free, while 50% have mild symptoms, and only 10 to 20% different symptoms. Frequency of the attack can be fluctuate, and then those who have depression can complicate the symptoms. And 40 to 40% of all patients with panic disorder have depression. And then in panic disorder, although the patient do not tend to talk about the suicidal ideation, they are at increased risk of committing suicide. And then last one, patient with good premorbid function and symptoms of brief duration tend to have good prognosis. Okay, so that's all from me.
Any question about panic? So essentially, what is panic? Panic disorder. Essentially, what is panic disorder?
It is like an intense fear, but it's accompanied with the the symptoms that our friend has just talked about, the SOB, the chest pain.
Go on.
So it's both psychological and physiological.
Rindu tak dengar announcement ni? Hanya seorang penjaga dibenarkan untuk menjaga pesakit jiwa pada satu-satu masa. Sekian, terima kasih. Right, so panic disorder. So, we develop panic symptoms for various reasons, kan? For various reasons, we develop panic symptoms. You go to exam with unprepared, you become panic. You saw your ex unexpectedly, you become panic. And then you dah order dekat McD, tiba-tiba tak bawa back duit, you panic. And so we have so many reasons to get panic in life. But what's different between that kind of panic and this panic is, in panic disorder, most of the time, it is unexpected. The panic attack itself is unexpected. It comes when the patient expects it less, or the least. And while the patient develop all the panic symptoms, ataupun most of the panic symptoms, i.e. physical symptoms and cognitive symptoms, physical symptoms tu yang palpitation, tremors, shortness of breath, butterfly in stomach, lump in the throat. So those are physical symptoms. Cognitive symptoms of panic are, am I going to die? Am I losing control? So those two are cognitive symptoms. So these symptoms patient experience unexpectedly, recurrent, and usually short-lived, 15 minutes or 20 minutes. So dia macam bell curve, dia naik slow-slow, and then dia sampai satu peak, and then dia akan turun balik. Dan benda tu berlaku secara berulang-ulang juga. Usually tidak ada trigger. So because benda ni berlaku secara tiba-tiba dan tidak ada trigger, tidak boleh you don't expect it, so you're afraid that you're gonna get it again. So you have that anticipatory anxiety. Bila lagi aku nak kena? Bila lagi nak kena? So anticipatory anxiety is a must. Or kalau anticipatory anxiety tidak ada, patient akan ada maladaptive changes. Maksudnya dia terpaksa keluar ataupun dia terpaksa bersama-sama dengan orang lain juga. Dia tak boleh berseorangan. Okay. So maladaptive changes. Dan benda tu berterusan, you have to rule out medical cause, you have to rule out thyrotoxicosis, you have to rule out substance, you have to rule out caffeine, you have to rule out epilepsy, yes, focal epilepsy, sometimes they can come with anxiety symptoms. So once benda tu semua dah rule out, cardiac cause semua dah rule out, dan bila benda ni persistent, then what is more prominent that is the fear, then kata patient ada panic disorder. Sometimes we do have several symptoms, some symptoms, but tak ada anticipatory anxiety. Ataupun attack tu expected. Kita tahu sekejap lagi aku nak kena attack. Dalam kes-kes yang macam tak fulfill panic disorder tu, kita kata just panic attack specifier. It's a panic attack specifier. So korang dah dengar apa ni, presenter tadi present pasal panic disorder dan apa yang saya sebutkan. What is the underlying fear in panic disorder? Essentially, akhir sekali, apa yang dirisaukan untuk orang-orang yang dapat panik?
Fear of recurrent attack.
Itu superficial, atas. Di dalam lagi tu, apa yang dia risaukan bila kena panic attack?
Consequences
Like
losing control or going crazy.
Losing control and going crazy. Do you think that's the last one?
No.
What is the last?
Heart attack.
Heart attack. What is the last one?
Fear of dying.
Die.
So it's a fear of dying. It's a fear of death. So now you can see, only by understanding panic disorder, the nature of panic disorder and the fear, then only you can integrate spirituality into treatment. Sebab death is a spiritual concern. Death is a spiritual issue. It cannot be treated biologically sahaja. So you can give medication to reduce the anxiety, but the question itself, what if I die now? Where am I going to? What would happen to me after death? Those questions can only be answered by your beliefs lah, by your religion ataupun whatever your beliefs are. So that's where spirituality is concerned. And when the presenter talk about, dia cakap tadi spiritual intervention, dia sebut pasal spiritual assessment, pasal KAP, it's actually beyond that. It's not just knowledge, attitude and practice of religion. I know that many of your seniors used to say that thing, tapi it's beyond that lah. So spirituality berkaitan tentang connection, your connection with your friend, ataupun you taking medication with the belief that God cure your illness. It's spiritual. So how to assess that thing in your patient? There are certain spiritual practices yang macam boleh soothe ataupun calm the patient down. So how can we know about these practices? Only through inquiry, kan? Asking the patient the right question, then only we know patient spiritual potential ataupun patient strength yang mana kita boleh gunakan dalam terapi. So without a proper assessment, we cannot integrate our psychotherapy and spirituality. Anyway, for panic disorder treatment, for biological, you're gonna the same medication. As for psychotherapy, we have one cognitive behavioral therapy and mindfulness therapy, the main one. And in cognitive therapy, kita nak ubah fikiran dia tentang panic. Many of patient yang ada panic disorder, dia rasa jantung berdebar-debar, bererti I'm going to die soon. I'm going to have a panic. I'm going to have a heart attack. But is it necessary so? Is it wajib to have sakit jantung? Or there are actually many causes? So there, you can actually identify patient yang ada panic ni, dia punya fikiran tu fokus pada satu je sebab. The selective, it's catastrophizing. Ni cognitive distortion. Cognitive distortion. Maksudnya fikiran yang herut. Maksudnya jantung berdebar-debar bererti aku sakit jantung. So dia ada jump into conclusion dan fikiran tu catastrophizing. So dalam cognitive therapy, we want to change this unhealthy thinking to healthy thinking. Because by changing the way of thinking, then only you change the response to that. How patients respond to that. Dan mereka akan avoid aktiviti-aktiviti yang melibatkan exercise ataupun anything yang menyebabkan jantung berdebar-debar. Sebab dia takut bila aku exercise hari jantung berdebar-debar, takut macam panik. Kan? Dan bila macam panik tu, again pergi ke fear tadi, takut nak matilah, takut nak sakit jantung dan sebagainya. So that's the thought process in patient yang ada panic disorder. Okay. I think I have to stop here. Kita tidak habis lagi general anxiety. Husna siapa?
Saya.
Yang mana?
Saya kat sini.
Oh, awak yang Husna. Okay. Right. Boleh tak nak present sekarang? Bolehlah present sekarang. Present lah, habiskan cepat.
Okay, so I'll proceed with generalized anxiety disorder next. This is the definition: pattern of frequent persistent worry that is out of proportion and impact of the event, and it is excessive, different than normal anxiety. And then next. Okay, it is a common condition. About 25% have GAD in anxiety disorder clinic, and also it is also high in primary care setting. The prevalence is according to the United States and Europe, and women are likely to have GAD at 2 to 1 than men, and the onset is usually in late adolescence or early adulthood, but commonly seen in older adults. Next. And the comorbidity are the most common one is the major depression disorder and other anxiety disorders such as social phobia, specific phobia, and panic disorders. They can also be associated with substance abuse and also chronic pain. Okay, next. The etiology can be further divided into two, which are biological and psychosocial. The biological first is the genetic, which means this is heritable. Okay, hereditary. So it has the same heritability with major depression and also neuroticism personality trait. And it also involves the main neurotransmitter, which are the GABA, serotonin, which is low in anxiety, and norepinephrine is high in anxiety. And based on the PET scan, it shows that the metabolic rate in basal ganglia and white matter is low in patient with GAD. For the psychosocial theory, there are two: cognitive behavioral theory, which means the patient with GAD will respond to incorrectly and inaccurately perceived dangers, and they give the selective attention to negative details in the environment, such as the distortion of the information processing, and also they will overly negative view of the person's own ability to cope. And also it also because of psychoanalytic theory, which suggests that the anxiety is because of symptom of unresolved unconscious conflicts. So now it become the conflict from the past become resurfacing back. Okay, next. Okay, these are the criteria according to the DSM-5 for generalized anxiety disorder. First, A is an excessive anxiety and worry more days than not for at least 6 months, and it is difficult to control the worry, and it have to be associated with 3 or more of the following 6 symptoms. And only one item is required for children. So first is restlessness or feeling kept up or on edge. Second, being easily fatigued, difficulty concentrating or mind going blank, irritability, muscle tension, and also sleep disturbance. Next. And also this anxiety and worry must be clinically significant distress and cause impairment in the social, occupational, or other important areas of functioning in patient. And we must also exclude physiological effects of substance or other medical condition, and it is not explained by other mental disorder. Okay, next. Okay, so these are the differential diagnosis. The differential diagnosis can be further divided into psychological, psychiatric disorder, and also medical condition. So these are the psychiatric condition that have the same symptoms. So first, depression, because depression and GAD have the same features, but depression is more on the self-critical on previous event, but GAD is more on the future event. We worry about the future money, about our health. Okay, and then hypochondriasis, more about the worry about illness, but GAD is more about many different things. For panic attack or panic disorder, okay, for panic disorder, it differs from GAD is when the panic attack in GAD, it arises from escalating and uncontrollable worry, but panic attack in panic disorder, it arises unexpectedly. Okay, and then the adjustment disorder is when the residual category, when the symptoms does not meet the criteria. Or the OCD, OCD is different. It's when it have more primal fear, and separation anxiety disorder, it also different from GAD. It is more focused on losing the major attachment figure. Okay, next. Okay, the differential diagnosis according to medical is also the same because this medical problem has show the symptoms of generalized anxiety disorder such as irritable, palpitation. So such as endocrinological problem, hyperthyroid, nephrocalcemia, they will have palpitation, tremor, and also metabolic, have such as cardiovascular disease and anemia, such as because patient with GAD can have lethargy, feeling restless. So this is the same as CVD and anemia. And also, if medication related disorder, if patient is taking epinephrine or a patient taking analgesic containing caffeine or drinking caffeine as well, because patient can feel restless. Okay, next. So these are the investigation: biological, psychological, and spiritual. Biological, because we want to rule out the differential that before for blood count for anemia, renal profile, thyroid function test for the thyroid hypothyroidism, ECG for cardiac problems, and urine toxicology for the drugs. And then psychological, we take the collateral history, such as collateral history means the history from the caregiver of the patient, and also we assess the family support, do the back anxiety inventory, and also the generalized anxiety depression skills, score 7. And then for the spiritual, we use the KAP, but as I mentioned before, not exactly like that. We inquire the suitable question for the patient regarding the practice. Okay, next. So for the management can be further divided into 3: biological, psychosocial, and spiritual. Next. So the biological, first we use SSRI, which is the effective treatment for both GAD and major depression, as depression is the comorbidities. The mechanism of action, it will decrease the action of presynaptic serotonin uptake. So it will prolong time of serotonin available. So increase postsynaptic serotonin, and it will increase the serotonin activity, so improve the mood of the patient. So the common side effects are sexual dysfunction, GI abnormalities, insomnia, withdrawal, and also other side effects. And then next. Okay, these are the examples of the SSRI that we use, and I also include the criteria for the treatment. Okay, next. Okay, second, we also use serotonin, the norepinephrine reuptake inhibitor. And the common drug use is venlafaxine, because it can treat the insomnia, poor concentration, restless and irritable, and excessive muscle tension in GAD. The mechanism of action is as in the next in the chart, and the common side effects are nausea, dizziness, insomnia, sedation, constipation, and sweating. Okay, next. Oh yes, about the SNRI, one of the common effect is it can it can cause hypertension. So if patient with hypertension, we have to monitor the blood pressure, and then if there is an increment, we can add or change the drugs for the hypertension. Okay, next. Okay, the next drug is azapiron or buspirone. It is more effective in the cognitive symptoms of generalized anxiety disorder. It has similar efficacy to benzodiazepine, but without the risk of independence. But its onset is longer than benzodiazepine, which is about 4 weeks. Okay, and the typical side effects are insomnia, agitation, and nausea. Okay, next. Is the pregabalin. It is analog to GABA, because generalized anxiety disorder, we have low GABA activity. Okay, so the side effects are sedation and dizziness, but they can also develop tolerance, withdrawal, and dependence. But it is this is better tolerated than benzodiazepine. Okay, next. Okay, then this is benzodiazepine. It is common is used in acute maintenance or long-term treatment of generalized anxiety disorder. It can be monotherapy or adjunct to antidepressant. Okay, the use is acute management of anxiety and worry to counteract the initial agitation for SSRI. It is an adjunct treatment, because SSRI can cause alertness, but we don't want to patient with GAD to be alert, so we can give benzodiazepine. Okay, so and then the side effects Okay, the main action, it can cause calming effect to the patient. Benzodiazepine. Okay, so the side effects are impairment of the psychomotor performance, amnesia, dependence, and withdrawal symptoms after long treatment, and rebound anxiety after short treatment. Okay, next. So these are the examples of benzodiazepine. Okay, next. Okay, these are the algorithm for to select the medication or to select the type of treatment for patient. First, we decide whether patient need the treatment or not according to the clinical assessment of the severity, extent of distress, and patient preference. So, when we have decided this, we go to the, if patient can do not proceed to treatment. If patient only have mild GAD, so patient do not have to receive any treatment. But if patient have co-occurring condition, patient preference for CBT or patient preference for medication, so we need to give treatment to the patient. So for patient with co-occurring condition, we usually give SRI or CBT, and patient preference for medication, we give the first line first, which is the SSRI and also SNRI. So next. So when we give the first medication, the SRI, we look at the response of the patient. If the patient have no response, no robust is no response, so we have to increase the dose until the improvement seen. But if patient have response, we continue until 12 months and then we terminate. But if patient relapse, we should resume the medication and extend the length of treatment. If the patient still relapse 2 times, we should consider ongoing maintenance. Okay. If patient does not respond, okay, and then we continue with increment of dose, then patient will have partial response or still no response. So if patient with a partial response, we should adjunct with another second line medication or with adjunct with CBT. Or if patient has still have no response, we no improve means that no improvement after 4 to 6 weeks. We should taper off the current medication and give another medication. Okay. Then next. This is the psychological treatment, can be further divided into 5. But the most effective one is the the CBT, because there are clinical trials that found this to be effective. But there are indications which only the highly motivated and patient that values problem solving. So this principle is to teach patient cognitive and somatic coping skills to manage the anxiety. Okay. As they are exposed to anxiety provoking image. So we teach the patient to identify their worries, and then we teach patient how to tackle the worries. And then second is the psychodynamic theories. It focuses on the core conflictual relationship themes. It will provide corrective emotional experience to offset the insecure attachment. And then we give psychoeducation regarding the patient disease itself. And then we give supportive therapy, which will offer patient reassurance and comfort. I'm not sure how it is done, but I researched that the doctor give praise and support and address the patient problem that patient tell. Like if patient is if it's worried, which patient is have low self-esteem, then doctor give comfort and provide ways how to increase it. And also lastly is the acceptance and commitment therapy. It combines the mindfulness of with acceptance of internal states and orientation of action toward the valued goals. Okay, next. And lastly is the spiritual treatment. Okay, spiritual means relating or affecting the human spirit soul, but and also it related with religion. So religion means the relationship with God. So the aim are three: to supply robust and flexible framework for understanding world and self, and also to increase tolerance to uncertainty and enhance coping, resourceful, and optimism. And also when spiritual, it can offer community support, so it will reduce social isolation. So one way is by doing prayer, when special attention is given to posture, breath, and space when occupied. So this goal is to exercise willingness to let thoughts come and go while using sacred word as a refocusing tool. So this is from up to date. Right, for Muslim, which this like we're performing our prayer, or we do doa. I think that's next. Let's say it's a prognosis. It is a potentially chronic illness, and it is with significant degree of functional impairment. But the cause and prognosis is not difficult to predict because they have maybe many comorbidities. Okay, that's all.
Okay, ada soalan?
I have question for the medication part. What is meant by robust or not robust in the chart?
I couldn't find the the meaning exactly, but I think this just means it respond and don't respond.
Yes, that's the meaning. Whether the patient responded to medication or not responded to medication within 2 weeks.
Okay, thank you.
Lagi soalan? Dekat ruangan komen saya ada tinggal 2 link. Satu link video, satu link guidelines. If you like to read, then you go for the second link. It's a guideline on anxiety disorder by Canadian punya guideline. So some people want to read more, then you can go for that. The first link is a video of a forum that we had last week in Gombak on spiritual healing. So you can listen to that forum, and then if you have any question later you can ask. Ada soalan apa tentang presentation tadi before we go for lunch? Jika tidak ada soalan, okay, we're gonna meet back on Monday for psychopharmacology, right?